What's up, guys? It's been a while. Ken and Omertag here with the Lightboard videos. We're going to talk about recurrent pregnancy loss. This is the first of a three-part series. In this first video, we're just going to talk about definitions. In the second video, we'll talk about the workup, and in the third video, we'll talk about the approach to treatment. A lot to say about recurrent pregnancy loss. Let's first get to the definition. What is recurrent pregnancy loss? Recurrent pregnancy loss is when you have two or more clinical pregnancy losses. Well, what's a clinical pregnancy loss? A clinical pregnancy loss is a loss in which there is ultrasound evidence of a pregnancy. So if you get to 7 weeks, they do an ultrasound and they see a little gestational sac, or they see a fetal pole, or they see a yolk sac, any kind of structure that's seen on ultrasound indicative of a pregnancy, that's a clinical pregnancy. The other defining criteria is if, let's say, you pass some tissue, you never had an ultrasound, but you passed some tissue, and then you sent you saved it and took it to the doctor, and the doctor sent it on, and it confirmed pathologically that yes, this was pregnancy tissue, then that is histopathologic evidence of pregnancy. Okay, so if you meet either one of these criteria, that defines a clinical pregnancy. So in order to meet the technical definition of recurrent pregnancy loss, you have to have two or more clinical losses. Okay? Now, what you'll notice that I didn't talk about is chemical pregnancies. So where does a chemical pregnancy fall? Well, a chemical pregnancy, for those that might not know, is a pregnancy in which you have maybe a positive home pregnancy test. Maybe you have a positive blood pregnancy test that is maybe greater than 5, goes up maybe to, I don't know, it could go up to 70, it could go up to 200, 2,000, whatever. It just keeps going up, but eventually it starts coming back down or it's rising abnormally. It's chemical evidence of a pregnancy, but you never have documented evidence of where the pregnancy was, and no one ever saw the pregnancy either on ultrasound or had any pathologic evidence of pregnancy. So the reason, now, chemical pregnancies still hurt the same as clinical pregnancies, so I'm not trying to make a distinction in the emotional burden between the two. They are equally burdensome and distressing. But when it comes to studying recurrent pregnancy loss, in order to study recurrent loss patients, you have to have strict criteria defining groups. So the academic definition is 2 or more clinical losses. Now, practically, some people will initiate a workup if there's 2 chemical pregnancies, or 1 clinical, 1 chemical. Sometimes people will just initiate a workup when there's 1 pregnancy loss, just because patients are anxious and want to make sure there's not something wrong, which is totally valid. But the recommendation is to do a workup for recurrent pregnancy loss in those who have more than 2 clinical losses. And the reason for that is because at this stage, the incidence of finding something is a little bit higher than if you just had 2 chemical pregnancies. So goes the logic. So again, just an introduction to how you define it. It is nuanced. And again, talk to your OBGYN about what's right for you if you're a patient listening to this. But this is the definition of recurrent pregnancy loss. In the next video, I said we're going to talk about workup. Before we get to workup, I think there's 3 things that I tell patients all the time to think about. First of all, pregnancy loss is actually not that uncommon. 15%, let's go with a different color here. 15% of clinical pregnancies will miscarry. And that goes up as the age of the woman goes up. So miscarriage is actually not that uncommon. It's just really painful to talk about. So there is a good chance that you know someone immediately in your circle of friends, family, that has miscarried, but they've never gotten to a place where they feel comfortable talking about it. So miscarriage is not that uncommon. In fact, 1 in 4 reproductive age women may experience pregnancy loss during their reproductive life. This is just actually the tip of the iceberg. Down here, we know there can be up to 60% of pregnancies that are lost that we never know about, that are subclinical, don't even register into the chemical. Maybe if you were to check a pregnancy test every day while you're attempting pregnancy, let's say, the month of March, month of April, if we just took women who were getting exposed to sperm and had them do pregnancy tests every day, in some studies, up to 60% of people will register a positive urine pregnancy test. Now, that positive will be faint and then will be gone, but that is suggesting that some implantation event was starting or some embryo was available to make HCG, but it was short-lived, and then ultimately the pregnancy was lost and the progesterone came down and the patient shed their lining. So again, a lot of nuance here, but it's all to say that human reproduction is horribly inefficient. So that's the first point that I make with people when I talk to them, is that human reproduction is horribly inefficient, and pregnancy loss is not that uncommon. The second thing is 50 to 70% of the time, the workup for recurrent pregnancy loss is unremarkable. Again, 50 to 70% of the time, the workup for recurrent pregnancy loss is unremarkable. You don't find anything. Everything's normal. That can be immensely frustrating because people are looking for, why am I having these losses? What can we do to fix it? So I tell patients up front, look, there's a good chance that we might not even find anything, but let's make sure we're not missing something. And then the third point is simply to state that despite human reproduction being very inefficient, despite the agony of recurrent loss and pregnancy loss in general, there is still a good prognosis for going on and having a live birth, even if we do nothing. That's not to say we're going to ignore you and just say, we're not going to do anything. But that's just to say that this process can still work for you, whether you're doing fertility treatment, whether you're trying to conceive on your own and have no infertility. It's important to recognize that you will overcome this. It is just anxiety provoking because what you may have to deal with to overcome it and what obstacles might be in the way can cause a lot of frustration, anxiety, grief, and sadness, for lack of a better term, quite frankly. So this is the definition. This is some basic tenets about recurrent pregnancy loss and pregnancy loss in general. In the next video, we'll talk about the workup and the rationale for the workup of recurrent pregnancy loss.